Yes, okay, we are live now. You start, Rupesh.
Yes. Sir, I'll give an intro and then you can start up, sir. Yeah. Hello, everyone. Good evening. On behalf of Team ExRx India, myself, Dr. Rupesh from Peak Health Studio, Chennai, would like to welcome you all participants and the attendees of today's session. I would like to thank our co-organizers, Sai Ram Academy, Chennai, Physioactive Gurugram, for their constant support for us. I would like to congratulate our team leader and spine of our team, Dr. Chandramohan, for organizing and executing this program. I welcome our technical coordinator, Professor Duna Saha ma'am from West Bengal. And our today's topic is physiotherapist perspective of dermatomes and will be explained very clearly by our own Dr. Saravana Ganesh sir, MPT Neuro Professor from SRM College of Physiotherapy, SRMIST. Sir, welcome, sir, and please start the session, sir.
Thanks for the introduction, Rupesh. Hello, Chandramohan and Duna. We go inside the topic. It is a dermatome, so I took it as a challenge and took dermatome because as a physiotherapist point of view, it will be a small part in our assessment. So I just want to, therapists should know more about dermatome related things. So we go to the presentation. I start sharing my screen.
Yes, sir.
I hope it's visible.
It's going to start.
Yes, sir, it is visible.
Okay, the topic is physiotherapist perspective of dermatome by me, Saravana Ganesh, professor. And it is for ExRxIndia.org webinar Super League 20 Tuesday, 7 to 9 p.m. Okay, we go inside the topic. I think everyone knows about dermatome. Don't think it will be like an anatomy class. What is the dermatome? What are the areas? It won't be like that. It will be a topic itself, a perspective of physiotherapist. So we start with a simple definition. What is dermatome? And mostly it will be clinical related. Every slide I will say how it is related to clinics. So dermatome is a cutaneous area separated by one spinal. Now that is an important thing we have to understand. It is by one spinal nerve through both rami. There are two rami from the spinal cord. So both the rami combine and forms a spinal nerve. So from one nerve, one dermatome. One spinal nerve which separates the area of skin, we call it as dermatome. Cutaneous area separated by single posterior nerve root. So different people has given different definition for dermatome. So I have given the name, the year when they gave everything. So one way they are saying it's a spinal nerve, another way they are saying the posterior nerve root ganglion. So from there, whatever we get information through the posterior nerve ganglion, we call it as the dermatome. And they say one spinal cord segment. We have spinal cord. Each spinal cord is divided into segments. Each segment has a one dermatome. So we can say C1, T1, T2, T3. So T1 has one dermatome, T2 has a dermatome. Like that also they say about dermatome. And apart from that embryology, they say a tissue which comes from somite. It's a part of dermis. That is why it is called dermatome. So different way we can say about the dermatome. Now, again, it is a peripheral nervous system, again divides into somatic nervous system and enteric nervous system. And so somatic nervous system is one we are going to relate because it is about the body movements and where specific sensory sensory fibers located in the skin and how this takes information from the skin to the central nervous system. So as the term itself says, the dermatome, the derm means it's a skin. So it is a part of integumentary system also. And this lot of nerve endings, lot of receptors for different sensations like heat, cold, touch, pressure, vibration, and tissue injury also to the spinal cord, to the brain. So in this, CNS is also responsible for the information, even though it comes from dermatome, this cutaneous nerves through the afferent nerves, it goes to the spinal cord, then to the primary somatosensory cortex, where you perceive what is that pain, what is the touch, what is that, those things under the perceive through those things at primary somatosensory cortex. And in our body, we have 30 dermatomes, but I earlier told it is each spinal segment has one dermatome, but we have 31 spinal segments. I am saying it's 30 because C1 doesn't have a sensory root. So your dermatome starts from C2 only. All the dermatome starts on C2 to coccyx level, it will be going. And it is throughout the body, dermatomes are pattern. The pattern of dermatome may vary from person to person. They say it's like what you have a fingerprint like that. The dermatome also differ from patient to person, and there may be also overlap of dermatome. Whatever we see in picture, we see a definite areas of dermatome, even though we see like that. But actual thing is there's an overlap of T1 over T2 or L1 over L2 like that. And dermatome are named, that is named more numbered based on the spinal nerve which supplies the spinal segment. The spinal nerve which comes from which spinal segment, that number only we give to the dermatome.
Sir, sorry to disturb, sir. Your voice is breaking.
So, whether this dermatomes are now it's now we can hear.
We can hear.
Hello.
Sir. It is not clear, sir. It is
Hello?
breaking.
We can hear you, but sometimes your voice is breaking a little. Hello, sir. Are you there?
Okay. I try to hold that mic near to my mouth itself.
Yes, sir. Please.
Can you hear me?
Yes, sir.
Now I will try to hold my mic to the mouth itself. Now can you hear? Hello?
Yes, sir. We can hear you, but sometimes voice is breaking.
Okay. I think I'm moving my mic. That's right. Okay. Now we come to know whether why these dermatomes are clinically important. So we have to know it's a fundamental concept in human anatomy, which is very relevant to clinical practice because we see changes or we come to a conclusion where is a problem by seeing a dermatome level, particularly in neurology and orthopedics. Dermatomes are key factors in clinical decision making, that is clinical diagnosis, particularly related to radiculopathy, that is a nerve root problem, or it can be also prolapse, intervertebral disc prolapse, or other causes. In neurology and orthopedics, we depend more on dermatomes. And in spinal cord injury, this dermatome plays a very important role in deciding what is the level of spinal cord injury. And apart from our field, in intraoperative monitoring also, this dermatome and dermatomal somatosensory evoked potentials are very important. So dermatome is closely related to clinical practice. So why again it continues, why dermatomes are clinically important means it gives a correct diagnosis of a neurological disease, whether it's purely sensory or motor or a segment is involved. Like that, we can give a correct diagnosis using a dermatome evaluation. And it also helps to identify peripheral nerve lesion, whether it's a peripheral nerve lesion or there is a segmental nerve loss, that is any one segment only is affected, or 2-3 segments are affected. Like that, we can find using those dermatome assessment. And it also, we can say, level of spinal cord involvement. Involvement means if you take spinal cord injury, till which is the last segment, which is carrying all information about motor and sensory. We call it as a level of spinal cord injury. Below that, we call it as a affected part. So level of spinal cord involvement also is mainly based on dermatome evaluations. And apart from this, some visceral parts, they exhibit the pain through dermatomes only. For example, myocardial infarction, it typically shows the pain through the dermatomes like left shoulder, left chest, like that. And sometime in herpes zoster also, the dermatomal appearance of rashes helps us to find what is the problem in the patient. And it also helps to pinpoint the area that is cause of many medical conditions. So where is the problem? Whether the problem is in uh, the skin level, whether the problem is in afferent nerve level, like that we can find by using dermatomes. Generally, they use
Sir, sorry to disturb again, sir. Hello.
Because,
sir,
can you hear us? Excuse me,
it is
sir.
not clear. Hello. Yeah.
Sir, audio is very husky
Yeah,
actually.
I can hear. Wait.
Can you hear me now?
Sir,
Sir, would you like to try without headphone?
Hello? Hello?
Sir, would
Yes,
you like
sir.
to try without
hear me?
headphone? We can hear you, but sound is very feeble, sir.
Hello. Okay, okay. Now is it clear?
Yes, sir.
Okay.
Instead, you can switch off your video also, sir. So connectivity will be much more clearer, sir.
Yeah, then no problem. I will switch off.
Yes, sir.
Wait a minute. I have to stop sharing, no?
No need, sir. I'll close it, sir. Yeah, sir. You can continue, sir.
Okay. So again, it is clear now?
Yes, sir.
Can you
Clear,
hear?
sir. Yes, sir. Yes, sir.
So again, why dermatome is clinically important? It indicates the pathology that involves related nerve root. Which nerve root is
Sir, please
involved?
hold your mic little away from your mouth, please.
Okay. So this indicate the pathology that now it's correct?
Yes, sir, it is all right now.
So it involves related nerve root. So from dermatome evaluation, we can find which nerve root is involved. Because as it is from the spinal segment, so which nerve root involved also we can find by doing a dermatomal examination. And particularly in radiopathies, radiculopathies, pain from radiculopathies can follow one or more dermatome. So from the pain part, that is a distribution of pain sensory loss, we can assume that which nerve root can be a problem. So in radiculopathies, it will be useful for us to find the level of injuries. And again, as I told earlier, pain and rashes over a particular dermatome can be seen in this dermatomal conditions also. So this one shows what we spoke. So first diagram shows about the how S1, L5, L4, L3 patterns of dermatomes will be affected. By seeing this pattern, we can have a clue which segment will be affected or which nerve root may be affected. This right side picture shows about the upper limb dermatomal pattern. So this shows that whether C5, C6, so different area. Can you see? So it is of different area. C5 means the dermatome affected will be different. C6 means the representation of pain is different. So we can get a clue where may be the problem. Again, how it is important means Asia scale. You can see the Asia scale throughout the scale. Dermatome, they're given a more importance for the dermatome in this Asia scale. You can see most of the pictures of dermatome, anterior posterior view, head, neck, and every sensory aspect, that is dermatome evaluation in Asia scale, to find what is the level of spinal cord injury and to find which category the spinal cord injury patients will come. Okay, again, we come to the same thing. Sensory level is often several segments below the actual level of lesion. So this one, I think most of you will be knowing, as spinal cord grows faster and the vertebral column goes longer, the spinal cord ends by L1, lower border of L1 vertebral column. So if we see fracture at any part of the bony part, that's vertebral body, we can't say correlate with the spinal segment. So sensory loss, it may be below. Why it can be like that? They say ascending spinothalamic pathway makes a more lateral fibers carrying. So if you see a spinal cord, next slide we'll be seeing, if you see a spinal cord, the arrangement of the afferent information going pathways, that is ascending pathways, ascending fibers will be arranged such that outermost will be the sacral, innermost will be the cervical. So mostly if there is an injury to the spinal cord from outside, first lower limb sensation will be affected because outermost is the sacral. So first sacral will be affected. Still, if the injury penetrates inside the spinal cord, then only cervical comes to be affected. So that is one way they are saying organization of ascending spinothalamic pathway. And another thing they are saying is because of blood supply, injury to the blood supply to the spinal cord, because one part of the spinal cord injury, the blood supply will be affected. So another part of spinal cord will be without blood supply. So those features also you can see in the dermatomes. So what clinically, what you understand from this is if you see a level of dermatome, you are getting one idea. At the same time, you're seeing the muscles, you get another idea. So there'll be confusion. So if it is like that, then mostly you can go with the motor level than with dermatome, because dermatome have the problem that it can influence other areas also because of, as I told, blood supply to the spinal cord, or it can be because of arrangement of pathways, ascending pathways. So if both there be a confusion or it is a conflict between motor level and the dermatome level, we can mainly go to the motor level and we can do a clinical decision making. This is a spinal cord I told. See, as my cursor is going on, the arrangement of tracks, ascending tracks were sacral, outermost, lumbar, thoracic, cervical. If there is an injury like this, first sacral will be affected, then only cervical will be affected if it is the lower body. As spinal cord ascends up, then once sacral area will go, lumbar will be the outermost, then thoracic will be the outermost. In cervical region, only cervical will be the outermost. This is the way we are saying if there is what we saw in the last thing, if there is injury, sensory loss maybe to the lower limb, sacral level. Then another thing we have to, as a physiotherapist, is referred pain. Referred pain is a pain from viscera to the brain. This viscera have anal segment representation in the brain. So brain thinks from where it doesn't know where it comes, and sometimes it may thinks that it may be coming from the dermatome. So it's a conscious perception. Referred pain is a conscious perception of visceral sensation because will have the same meant to the dermatome. So visceral same the same. For example, if it is a L2 L3 means this L2 L3 skin dermatome will have show a pain. So we say it as a referred pain. It is not purely on the dermatome, but it is because of some other organs. You can visceral organ which show dermatomal changes or pain over which area over the skin. This we have to consider while taking a assessment, dermatome assessment. So before going to the dermatomal assessment technique and purpose of assessment and technique, we should know about what are the sensory neurons present in the dermatome. And there are, as I told before itself, skin has a lot of neurons, a lot of receptors present in this, lot of nerve endings are present in the skin. We can categorize into epicritic neurons and protopathic neurons. Epicritic neurons detect generally about gentle touch and light vibration, and sometimes the shape of the object, 2-point discrimination and all will be by epicritic neurons. Protopathic neurons mainly detect pain, itching, tickle, and temperature. So I think these terms you should know when you are writing the assessment or when you're reading an article in a journal. They'll be saying about epicritic pathway or protopathic pathway or protopathic pain. The terms they will use like this. That means you have to understand this, the sensation from these neurons, they call it like that. Again, we have to know about the cutaneous receptors present. There are a lot of cutaneous receptors. I think all know those things. I will say only one or two. No need to go beyond that. It will be like anatomy class. So I will say only Merkel's disc, which will take the information of mechanoreceptors or a sustained touch on the skin. It will take as a individual specific property or function. So it will do like that only. And from the receptors, all the axons will be collected and goes as a nerve. So these axons collectively contribute to the somatosensory information to spinothalamic, that is from spine to thalamus, or spinoreticular lemniscus system. Then we call it as a protopathic sensation when it goes through this pathways. And if the receptors contribute to the somatosensory information to dorsal column, that is the posterior part of the spinal cord or medial lemniscus system, then we call it as epicritic sensation. It is mainly related to larger myelinated axons. So we go inside dermatomes. So I'm not, again, I told earlier itself, I'm not going to teach where and all dermatome, what are the areas of trunk dermatome. What you need to know, that one I'm going to say. What you need to know is trunk dermatomes. From the picture, you will be knowing it is arranged segment-wise. Clearly, it goes like a segment. From each side, you can see in trunk, it goes like this. Segments or present. It is mainly from posterior medial line to anterior medial. From posterior, it starts and it goes to the anterior. From posterior, it starts and goes to the anterior. So from posterior medial line to anterior medial line, the dermatomes are arranged like this. And as I earlier told, C1 is only exception. C1 doesn't have a sensory part. So if you see any dermatome, it starts from C2 only. So clinically, what you have to know means when you're checking the dermatome, you are checking dermatome will be laterally from the spine towards outside. Like this only you have to check the dermatome, but in limb, it will be differing. Again, trunk dermatomes. So what they say is tactile loss is larger than the loss of thermal. So they say tactile dermatome to detect the tactile sensation is larger in the sensation of pain or temperature. So this tactile has a larger area in the trunk. If you are clinical how to relate means, if you are going to check tactile in a trunk, you get lot of dermatomes involved like that. But if you check pain and thermal, you can see a few dermatome only involved. So checking pain and thermal will be more accurate to find which dermatome, because overlaps for tactile is more in trunk. degree of overlap of carrying pain and temperature is more extensive than all of fibers carrying tactile. So loss of afferent nerve function, the one spinal nerve could not generally cause. So they say if in trunk, if you say this spinal segment is affected, it won't be correct because there are a lot of overlap in the trunk. So we can't definitely say this segment is affected in a trunk dermatome. So by assessing the trunk dermatomes. Yeah, before going to the limb, you should understand the basic concept of dermatomes in embryo, what happens in embryo. So as you see the picture, as the embryo forms, the first one is upper limb, second one, that purple and color is a lower limb, yellow and green is upper limb. So as embryo grows, the limb, upper limb rotates laterally. So your thumb goes outwards. But in lower limb, it goes internally, medially. So your greater toe goes medially. This is a thing happens in the embryo level. How it is related to dermatome means, if you see, okay. Now we come to the how you relate means, if you see the picture in the dermatome, you can see arrangement of dermatome down at lateral side and up at medial side. For example, C3, C4 up, then it comes C5, C6, then C5, C6, C6, C7, 8. So laterally it comes down, but medially it goes up, C81, C81, T2, like that. In upper limb, it is because of rotation during the embryo level. Same thing in lower limb, if you see the arrangement is down in medially and up in laterally. So L2, L3, down L3, L4, then L4, L5, then laterally it goes up. L5, S1, like that. This is how clinically we can understand mechanic changes takes place in the upper limb, lower limb. T1 will come laterally or medially. Automatically, you should come medially only because it goes up in medial, down in lower limb. It goes down in medial and up in lateral. So you should not have a confusion. That's why I told I'm not going to take us. And so now you understand about limb dermatome. Another thing we have to understand is this dermatome of neck, posterior neck and head will be C2, C3. It goes upward. So as we see in the diagram, and T1 also is posteriorly placed. The C4 is continuous with T2, not T1. That you should understand. When you're examining also, you should understand that C3, C4, then it is not T1. T2 comes and merges with the area. That one you should understand. Don't make mistake while assessing that it is a T1. T1 is back in the posterior thing. Okay. So they say in the diagram itself, in the trunk, there are a lot of overlapping. They say comparatively in limb, you see it is very clear. We can clearly see this part is this dermatome, this part is this dermatome, this is S1, this is S2, this is C3, this is C4, like that. This overlapping is less in limb dermatomes, more in trunk dermatomes. Then we come to neck and head dermatomes. You can see the diagram, the dermatome, as I told, all is upward migration of everything goes up. See, C2 is there, C3 is there, C4, C5, C6. So everything is going up, migration of dermatome. So you can't see this C2, C3, everything mainly we see in the scalp. You won't see in the upper thing, as we saw in before diagram. And most of the phases by trigeminal nerve, not by spinal nerves. Trigeminal nerve supplies the phases, and second cervical merge with the trigeminal at one point, trigeminal, and it supplies a full scalp. So we come to the assessment. Why we have to assess the dermatomes? What is the purpose of assessment? So purpose of assessment, first one we can say it's determining the pathological disk level, which level there is a pathology. We want to know, do a dermatomal assessment. One. And we want to know whether sensation is intact or impaired, whether we want to know whether person has an intact, whether he can feel the sensation or then second aim of doing an assessment is we want to know whether we want to know which area the patient has a sensory loss. So we want to map out distribution of sensory loss in a limb, and we want to know which cutaneous nerve or which spinal nerve or lot of one spinal nerve or lot of spinal nerves are involved in this loss of sensation. That's why we do a assessment. And mainly we have to understand we are going to assess somatosensation only. It is information from the skin, muscular system, then it goes to the brain as it primary somatosensory cortex. So don't confuse with the sensation of sight, smell, vestibular system, even cortical sense. Don't expect proprioception, other things also. So this is purely dermatome I am speaking. Sensation is not the topic, dermatome. So whatever sensation related to dermatome only I am going to say. So again, we want to know whether sensory is integrity. Integrity means it is united. I want to know whether a sensation starts from my hand, goes to the spinal cord and goes to the brain and comes back to the spinal cord and comes to my muscles, whether I am reacting. So all these things should be united. So I want to know whether the sensory integrity, that is unity, is there or not. If there is a problem, if I'm not getting any response, means there is some problem in this circle. It can be in the nerve, it can be in the spinal cord, it can be in the cortex, or it can be the motor nerve. So I want to know sensory integrity of the nerve, and all this impairment is there. I want to know. In spinal cord in general, I want to know how long, from where to where I have the sensory loss. So I will determine what I have to do. All of my treatment is related to the loss of sensation in spinal cord and characteristics of sensory impairment. Which sensation is affected, which is not affected. So I want to know the character of the sensory impairment also. And not only I'm going to do a clinical decision making, or I'm not going to do a big diagnosis or level. For protective sensation also, I have to do this assessment. You will be knowing about neurological patients, chronic patients with permanent disability or with the loss of sensation. We have to protect them from the loss of sensation. We have to do a lot of safety mechanism. For that, we have to do a dermatomal assessment. Again, we have to know whether central nervous system and peripheral nervous system are united or not. I told earlier whether it's united or not. There is two principal pattern of sensory loss. How the sensory loss takes place in the dermatomal pattern. One is contiguous dermatomal overlap. There will be one nerve root, maybe a damage because no anesthesia, no sensory loss, or it can show a small area of sensory loss. This area is called as signature zone. Signature zone means that spinal segment shows loss of sensation at that area only. That is called signature zone. And particularly this is very important in
Hello, sir. Are you there?
No, ma'am, sir. Is there? But,
I think resource person is disconnected.
no, sir is there, ma'am.
No. Try to communicate with him, Rupesh.
Yes, ma'am. Yes, ma'am.
Mute your audio and then communicate.
Ma'am, sir is joining shortly.
All right. Participants, please wait you. There is some network issue. Rupesh, please don't add everyone, okay? Keep one place for resource
Yeah,
person.
yeah. Yes, ma'am. Sir, now
Hello?
you are unmuted, sir.
Now it is unmuted, I think.
Yes, sir. Now audio is also good, sir.
Okay.
So please share your screen.
Yeah.
Screen is visible, sir.
Okay. I think some.
No issues, sir. Network problem there might be.
Okay. Now it's clear.
Yes, sir. Sometimes
Am I
some
audible?
audio issues are occurring. It's clear now, sir.
Okay.
Please continue. Hello, sir.
Okay. Okay. So as we are dealing with two. Yeah. Hello.
Yes, sir. Please continue.
Hello.
Please continue, sir.
Hello. Can you hear me?
Yes, sir. Please continue.
Okay. Okay. So purpose of assessment, we are continuing to identify meaningful pattern of sensory loss. That is what it means for meaningful means the sensory loss, whatever you are going to record in a note or in your any way you're going to do, that should give a clinical idea that this is a part which is affected, or this area is not innervated, or have loss of sensation. So that is called meaningful pattern of sensory loss. So we do ask. So from this we can find where is a problem, and sometimes it is not associated with the motor reflex. Sometimes you may get L3, you may get L1, L2, but motor knee reflex will be a problem. So it is not associating with the motor assessment or reflex assessment or cranial assessment and thing. At that time, it shows that this dermatome as a weak evidence. We can't consider this dermatome as a main evidence to decide a diagnosis or decide a treatment. Clinical decision making we can't do. It becomes a weak evidence. If area of paresthesia coincides with the of cutaneous nerve, then we can think it is a peripheral. Clinically, what I want to try to say is peripheral nerve means it is a combination of 2 or 3 spinal nerves, mostly. There may be separate also. Mostly it is a combination of C81, C3, C4, C5, like that. 2, 3 spinal nerves combined and forms a peripheral nerve. So when you're doing a dermatomal assessment, if you think a particular areas, you find that that area is only affected. So if it shows that purely one nerve, then you can say it is a peripheral nerve. That particular nerve is affected. But if it shows broadly, then you have to think spinal segment, that is dermatome, which dermatome is affected. That difference you should know. Mainly, most of the physiotherapists think that cutaneous supply and dermatome are same. Dermatome is purely a spinal nerve related thing. Cutaneous sensation or cutaneous supply is mainly a peripheral nerve thing. Peripheral nerve is a combination of 2 or 3 spinal nerves that you should understand. What clinically it says means if uh, any particular dermatome it is not showing, you are assessing a patient, a particular dermatome you are not able to come to a conclusion, means it may be due to a spinal nerve and not a peripheral nerve. A particular nerve like ulnar nerve may be a problem. So one particular area only there will be a sensory loss or pain. If it shows a dermatomal thing, means it can be higher level problem that is not due to peripheral nerve. It is due to spinal segment. There is a problem in spinal nerve, higher level spinal segment, or it can be problem in central nervous system. So clinically, what you have to know is, if shows as a dermatome, the problem may be higher level. If shows only a cutaneous region, the problem may be a lower level. That is, a peripheral nerve is mainly affected. So again, the topic is about cutaneous innervation versus dermatome. So everyone should know the difference between cutaneous innervation and dermatomes. Cutaneous innervation is the area of skin which is supplied by a specific cutaneous nerve, only specific cutaneous nerve. That nerve, whatever it supplies area, that is called cutaneous innervation. But dermatome is by spinal nerve, as repeatedly I'm saying, because it should be registered in your mind. It is by a spinal nerve, one nerve, one dermatome. So it is less specific. We can't say to a particular area, less specific. And it is, if it is, what to say, if spinal nerve is more source of problem than cutaneous nerve, then importance given to the dermatome will be less. When cutaneous nerve is from different spinal nerves, then dermatome becomes important while assessing. What I'm saying is, if purely cutaneous nerve, it is starting from single spinal nerve, and this nerve is going to be affected, or whatever you get from that assessment is very important. The dermatome gets a lower stand, that is less specific. When you think uh, the problem is mainly from more of dermatome, if the cutaneous nerve is a combination of different spinal nerves, then dermatome becomes very important. We have to check dermatome than cutaneous innervations. Okay, so cutaneous nerve areas, sometimes it will be overlapping, and cutaneous generally broader, wider than the dermatome nerve. And peripheral nerve field is a term they use for area of skin innervated by a single nerve. A single nerve, wherever skin which is innervated, that they call it as peripheral nerve field distribution also. So this diagram, I want you all to note that what is the difference between cutaneous nerves. It's the same palm I have taken. The palm left side shows nerves which supply cutaneous innervation of the palm, this ulnar, median, radial. But see the same palm, dermatome innervations. Dermatome is different. If you see thumb, it is median, some radial, but dermatome totally C6. Same way, if you see the index finger, middle finger, it is by median nerve, area to C7. Here, 1.5 finger is ulnar nerve, but all 2 finger and half of the palm and forearm, everything is C8. So you should know the difference between the cutaneous innervation and dermatome. Dermatome is by spinal nerve. Again, I'm saying. So now we go to most awaited, that is a technique of assessment. Again, I am saying we all are physiotherapists or student. This dermatome assessment is not a big deal, but I want to say again because the clinical related to clinical thing how it happens. So technique of assessment is we are going to find a pattern or distribution of sensory symptoms like tingling, numbness, or absent of sensation or less sensation. So we are going to get information about these things. This will be helpful for physiotherapists to diagnosis and to decide a treatment also, particularly when you're going for electrotherapy or when you're going for other, even some exercise therapy and all, this dermatome assessment is very important. And another thing you have to understand is this sensation is purely subject to, so reliability is very less subject. That is what patient says we have to believe. So mostly it is a qualitative subject to assessment, what we say in the sensation. So technique mainly, so it saves a lot of time. So from distant nerve itself, if you find any problem, one test of full dermatome. So what we do is we test some areas. If we find any problem, then we test full dermatome. So it will be time saving, and we can test lot of multiple dermatomes within the same time, within a less time period. We can assess lot of dermatomes. If there is any problem, then we specifically go and map out which dermatome is a problem. And so whatever we get technique we use, so we can find whether peripheral nerve injury is generally present sensory impairment. So we can find which nerve is involved in that. Again, technique mainly we related to dermatome. Again, I am saying we are not going to assess the sensation related to dermatome: light touch, sharp blunt touch, temperature, 2-point discrimination. This is a different test we use to find. This will test even a small diameter nerve fibers to large diameter nerve fibers. Pinprick test we mainly use for pain sensation, and light touch test with use with cotton wool swab. And mainly we use that we ask the patient to close the eyes. Then we ask two important questions. That is, one, first important question is whether you feel the sensation. That is the first question should be. Second question should be where you feel the sensation. That's all. So if they say correctly, then there is no problem. So only two questions with the vision blocked, that is, patient should be eyes closed. They have to say whether they feel, one, where they feel. Two things only there we are going to do. So if they answer it, then that dermatome, there is no problem. If there is any problem, if the patient is unable to express, means then you can go for detailed assessment of the dermatome. Then we have to go for bilaterally, both the sides we have to go. Okay, now after assessment, what are the terms you should know about this sensation and dermatome related? It's analgesia. I think most of you know, loss of pain sensation. Dysesthesia, that is touch sensation, is considered as a painful. Hyperalgesia, that's the increased sensitivity to pain. They feel more painful. Hyperalgia, this decreased sensitivity of pain. Everything's related to pain, what you get over the skin. Allodynia is a pain provoked by non-noxious stimulus. That non-noxious means even a pen drive, it is not sharp, or you can have a pen, it is not sharp, but that will create a pain for them. Causalgia, that is they get a burning sensation throughout the nerve. So from assessment, what and all, again you get on related to sensation is autoprognosia, that is they are unable to localize a sensation. Then hyperesthesia, that is increased sensitivity of sensory stimuli. Hypoesthesia, that is sensory stimuli. paresthesia is an abnormal sensation. They get a pins and needles or numbness, loss of light touch. Light touch, they are unable to identify. So related to temperature, these three we are dealing. So thermal analgesia is unable to perceive heat. Then thermanesthesia is unable to perceive sensation of heat or cold, both. Therm hyperesthesia is increased sensitivity to temperature, opposite is decreased sensitivity to temperature. Apart from this, there is also some quantitative sensory testing also. I think you will be knowing about the vibration we test with tuning fork. 2-point discrimination, we have a caliper like equipment, and we have wheels with thorns. So sometimes we also use quantitative sensory testing, mainly for research purpose and for recording the progression and all, because mostly they expect more of quantitative assessment than qualitative assessment. We have to give some number to the whatever we assess. So we are trying to even sensory testing also, we are trying to find new equipments which will use for assessing the sensation over the dermatome. So we come to the dermatome maps, because we use this only from the UG student level to PG student level to the practicing physiotherapist. We use maps because we can't memorize all the dermatome. We immediately refer a book and see what is that, where is the dermatomal problem, everything. So what is a clinical reference of dermatomal map? Dermatomal map is very important because we refer them. But you see the diagram, what I have shared you, there is one map at the left side. It is by one author. That is a map by one author. This is by another author, that is Forrester, and this Keegan and Garrett. Can you see the L4 particularly? I'm taking only one dermatome. Particularly in this left side, L4 is in one map shows this. Second map shows L4 here. This is Gray's Anatomy book. Okay, so see the difference between the dermatomal maps we use. The cutaneous distribution of L4 alone we are taking. So what will happen if we use any one of the map and do a diagnosis? That is a thing we have to, everyone have to think, contemplate that what is happening. That is my important thing I want to say to all physiotherapists. We don't know that. Whatever we think it is correct and we follow that, we will see this. Before going to what is dermatome map, we have to know about the history of dermatome. A lot of people have framed dermatome map, have developed dermatome map with different techniques they have done. For example, 86, Wilmot Errington, that is dermatomal ES showed. I'm not going to say detail about the history and all. It is entry ed is formed a dermatomal map. And this is by Foster. Mostly we use this only. This made by 1933. This is by Keegan, and this also we follow. As I told earlier diagram, these two, Foster and Keegan and Gatlett. This another map they are following. So they say it's natural that there will be changes in dermatomal map. That's their natural variant. Each book they have different way in their colleagues. They found 14 different dermatomal maps, and they do a research why there is a variation. They found that most areas of skin are innervated by 2 or more spinal nerve roots. So one author says this is a spinal skin over which this spinal nerve supplies. Another author says some other thing, because one area is supplied 2 or 3 nerves. So there is a problem they are saying. Another thing is very importantly, you have to know, because we generally don't know this, that is intrathecally, inside the spinal cord, intersegmental anastomosis. That is between the segment, there is anastomosis of dorsal spinal rootlets. This dorsal spine have connection between the segments. So we can't correctly say which segment because to another spinal cord. So spinal segment. So they're saying we can't correctly say which spinal segment. That's why different authors says different mapping they're giving. So there are some research also going on related to this dermatomes. One of this is by Moshe Ita, 1989. He saw 100 adult cadavers and come to a conclusion that 61% of cervical, 7% of thoracic, and 22% lumbar dorsal roots have different, they have a intrathecal intersegmental anastomosis. As I explained to you, there's a connection between spinal roots. So one root is affected, another root gets connection from some other roots. They have a connection, they have found in the cadaver finding. Another interesting is Kirk continued down Brown, 1970, they found dermatal area greater neighboring spinal nerves. If they cut one spinal nerve and they find what happens, they are saying the neighboring spinal nerves or neighboring ganglia cells helps and come to do the function of sensation in this spinal nerve. So they are saying correctly, we can't say that this spinal segment supplying this skin. These two research shows that whatever we say, this spinal nerve, this spinal dermatome is not correct. So again, there is 73, the same person have done a research and they found that there is a facilitated inhibitory effect of neighboring nerve roots. And so they say sometime they help next spinal segment, this nerve root. So they are saying it's because of this facilitated inhibitory effect, you get a change in the dermatome supply. So this research is very important. It shows that whatever we see may be not correct, because in spinal level something else is going on. It helping or it is inhibiting the sensations. So we come to the physiotherapy books. This is a diagram which shows how many physiotherapy books have dermatome pattern. So whatever book we know is Maggie, Kistner, and Kobe. Maggie, they are not using any map what we told. They are not reference also. And Kistner and Kobe, they're using Keegan and Garnett, and pathology implication of physiotherapist. They are using Keegan and Garnett again, and O'Sullivan, they're using Keegan and Garnett. So mostly whatever physiotherapy books we follow, they're using Keegan and Garnett, and some people, they're not mentioning which one they're using by them, so they're not mentioning which mapping we are using. Do you think this is a problem for us as a physiotherapist? This inconsistency is a problem or not? Yeah, it's truly is a problem. It can affect students. As we are studying, it will be a confusion. Therapists who are treating the patient, it will be a problem. And for clinicians, when I am communicating to a doctor, this level of sensation loss is there will be a problem, because he may be following some other map, I will be following some other map. And it also gives a conflicting information. When I am saying about in a team, I am doing a teamwork with the occupational therapist, psychologists, neurologists, everything, at that time, a problem. So again, for students, when they're appearing for licensure exam or they're appearing for MRB exam, so if question setter has followed one mapping and student has learned another mapping style, so he won't get the mark for the answer, because he's question setter be expecting something else, student is writing something else. So it is a problem of maps. This is for your understanding I'm given. It's a 3 authors, anterior view, see the dermatomal mapping, how different it is. Dermatomal mapping of Foster, Eden Campbell, and Garrett, Keegan Garrett. 3 anterior view, and this is 3 posterior view. Totally, if you see, go inside, it will be confusing. What I want to say is, as a physiotherapist, you should know, as a UG student, you may believe certain things. It's correct. As you come to practice, you should also know that there is variations. So you have to know all the variation, then only you can cope up and do a better job. So what is the solution? This is mainly by Lee and et al. They, after doing a lot of research, seeing all the maps, dermatomal maps, they come to a conclusion and they formed one map that is called evidence-based dermatomal map. This is one that I have given the article also. It is 2008 article, evidence-based approach to dermatome map. So they are given a map for the dermatomes. Certain area they left blank. Blank area says that different maps, they can't come to a conclusion which is which spinal segment supplies these things. Spinal segments based on evidence-based. As we are going for evidence-based practice, evidence-based dermatome shows certain area, other area, they couldn't come to a conclusion at all. So as a last, I want to say how to remember, because most of you have confused how to remember. This diagram helps you to remember, because in this posture, typically you can divide cervical, thoracic, lumbar, sacral, and it is easily arranged. So you can easily remember. That's why I kept it last, because it will be useful for physio. So this diagram will help you to the dermatome very useful. So conclusion, I say that this dermocutaneous distribution, everything should be re-evaluated, because dermatome maps, what we get is from 19th century maps. So still there should be a lot of research should go on clinical anatomy, and they have to find a lot of things. We can't do, as a physiotherapist, we can't do that research. So is try to follow evidence-based dermatome maps if it is possible. If it is not possible, try to find or follow one map and try to get knowledge from another map also. There are important 2-3 maps only are available. So if you have a confusion with one mapping, dermatome mapping, you go for another dermatome mapping and come to a conclusion about which area is affected or for treating the patient. And one thing you have to think over is whether, because of this mapping problem and all, whether dermatome we are diagnosing is really the location of dermatome we are doing. That is a big question. Everyone have to think. You also think and say. So this is my source of information. So this is my thing. If you want, you can contact. I think I've finished.
Yes, sir. Sir, can you hear me, sir?
Yeah, I can hear you.
Yes, sir. It's a few
Sir,
questions.
please join.
Can I stop sharing? Or
Yes,
it will
sir.
be there?
Stop sharing, sir. Stop sharing and you come on video.
Okay.
Yes,
Good evening,
sir.
sir.
Yeah.
Few questions are there, sir.
Yeah, you can ask.
Yes,
In the
sir.
chat?
Yeah, in the chat. I'll read out, sir. You can.
Okay, okay.
1 second, sir. Yeah. So first question is from Mr. Jitendra.
Yeah.
Sir, can we say dermatomes have a prognostic value also in addition to diagnostic value?
I think he's asking about therapeutic use of dermatome.
Yeah, yes, sir.
Prognostic value means he's asking that. Yeah, you can use, for example, when you are giving treatment like based on roots approach, or you are going to stimulate, generally we stimulate the dermatome related to the muscle. If C3, C4 I want to activate, I will stimulate C3, C4 dermatome, and I will expect some changes in the muscle. As I told, this will go to a spinal cord. From spinal cord, there will be a efferent fiber comes to the muscle, and there is a concept like that, using dermatome and treating the patient. Yeah, there is something. But roots and all old. That's why still we are practicing. But we are all the research and other people have come out of this, and they are going for some other later techniques in treating neurological patients.
Yes, sir. Next question is from Dr. Ria. Sir, please suggest way of memorizing dermatome map.
That's why I gave that last slide, because it was forward. Typically, it says cervical separately, thoracic separately, lumbar separately, sacral separately. In standing, there will be confusion. That's why I told that will be easy to understand. Anyway, no need to memorize. I don't know whether he's a student or a therapist. Now, concept of education, learning itself changed. It is not memorizing. It is producing. So you have all the information in your mobile, net, everything. No need to memorize. Whenever you want, you can go and browse. Why you want to think memories? It's older days. I think I will explain.
Yeah. So convinced, Ria? Yeah. And the next question is from Ms. Nitya Selvam. Explain synkinesis and treatment if possible.
Synkinesis is abnormal movement of muscles. If there is after the injury of nerve, again it will reboot. That nerve will start work. At that time, it won't correctly connect to that particular nerve. It may connect to some other nerve, so some other muscles will act according. I mean, when this nerve is stimulated, some other muscles also will be stimulated. That is totally different topic, and there is a treatment for that, but it is very preliminary stage. One of my students has done electrical stimulation and all for facial sensitivities, but it is not very effective to say the truth. There are treatment.
Fine, sir. For your appreciations in between, sir. And next question is from Ms. Pooja. Yeah. Which dermatome map is best to learn for a second year student, sir?
Okay, second year student, you believe that all dermatome maps are good. That's all. My answer is. So whatever your staff says, that is a correct map. Whichever your colleague says, you follow that.
Fine, sir.
Mainly for therapist means I will say differently. Second year student, you follow whatever anatomy sir says. Or your therapist says. Staff says.
Next is from Ms. Sobia. Please explain difference between dermatomes and cutaneous sensations again, sir.
Okay, cutaneous sensation is by one nerve. Ulnar nerve as a cutaneous part. Cutaneous nerve, I mean, they are motor and cutaneous. It's a mixed nerve. All peripheral nerves are mixed nerve. So cutaneous part will be there, motor part will be there. Cutaneous part again supplies some area of body. But ulnar nerve is made up of, not made up of one spinal nerve. It is made up of 2 or 3 spinal nerves. So this cutaneous innervation means it is getting information from the area which is supplied by 2-3 spinal nerve. Dermatome is only one spinal nerve. T1 means T1 segment only involved. But ulnar nerve means that we see ulnar nerve means it may be C5, C7, any part of spinal nerves will be combined and it will be supplied. So sensory, that is cutaneous, is from peripheral nerve. Dermatome is spinal nerve. 2-3 spinal nerve combine and form a peripheral nerve. So this peripheral nerve examination, cutaneous supply doesn't give correctly which spinal nerve is affected. Radial nerve area, sensory area is affected means it can be CAT1, anything, C7, CAT1. So we have to find again which is affected. If it is T1 alone means dermatome, why you are checking means we can clearly say T1 is affected. That's all.
Fine, sir. Next question is from Dr. Kalpana. Sir, kindly share the details regarding the app of dermatomes as mentioned by you, sir.
App? I think I didn't mention any app. Anyway, I also checked app because all younger generation, they want to do in mobile. But there is some app for quiz in dermatome. So you can participate in that and you improve your knowledge in dermatome. I think there is one app related to 3D dimension of dermatome, but it is not in English. I checked. It is some other language. I couldn't understand how to proceed in the app itself. That is a real thing. I checked because I know the I know the audience are young. They need app. They need everything. The education itself changing. I know. I checked everything.
Yes, next is from Lakshmi Prabha Kalyan Raman ma'am. Hi Saravanan, this is Lakshmi Prabha. Well explained. If it is detailed much on PNL, more useful maybe. She was asking you something.
Yeah, again, to say the truth, that the topic is dermatome. So I can't say about all the sensation. That's why I told the topic is dermatome. So related to dermatome, I have spoke. I can't speak about proprioception also. Proprioception is from muscle and bone. So I can't speak about that. I can't speak about the vestibular, all the sensation. I can't speak about other things also, vibration and all. Mainly, I'm dealing with dermatome. That's why I'm saying about few dermatomal sensation. That's why I told whatever neurons, whatever receptors in derm, that is skin only I'm relating.
Ma'am, if you want to speak, you can. Ma'am.
Saravana, how are you?
Fine, madam. Good evening, madam. How are you?
Actually, very nice. Well explained, actually. But so many students are watching, so that I suggest that's it. Nothing else. It's
Oh,
very
no problem. That's a good suggestion only, ma'am. I'm not.
yeah,
No,
very,
no.
very
I have to
okay.
be
Thank you.
bond with topic. That's why it's like that.
Yeah. Okay. Understand. Thank you so much.
Thank you. Thank you, madam.
The next question is from Miss Anisha Singh. Sir,
Yeah.
can you once again explain why dermatomes are clinically important?
Clinically important. So, particularly in neurology and orthopedic, as I told earlier, orthopedic and neurology only we concern more about the dermatome. If you say peripheral nerve lesion, radiculopathy, that is nerve root involvement. Wherever there is a nerve root involvement, we have to find which nerve is involved. To say the truth, when we were a student, we have to do physically all the examination and come to a conclusion that this is a spinal segment which is affected. But I think nowadays why that is missing means mostly it is MRI scan or CT scan they do and they come with diagnosis. This level is affected. So that practice has gone. Before what we do means we will assess the dermatomes, we will assess the muscles, then we correlate whether this muscle, for example, C56 biceps is weak. C56 dermatome also there is a loss of sensation. So there may be problem in C56 at the spinal segment level. That is a clinical importance. So I will diagnose myself later to the dermatome assessment. In treatment part, I have to know that where is the loss of sensation, because when you're going for a electrotherapy or when you're going for any other treatment, if you're going to put a brace, we can't put a brace very tightly to your region where is loss of sensation. Even in wheelchair patients, we have to keep on providing them safety, keep on giving them instruction not to have pressure sores or anything. So sensory loss, dermatomal region is very important. And another thing is particularly in spinal cord injury, that level itself is decided by dermatome assessment only. That's why I showed the Asia scale. They give more importance, equal importance to motor and sensory. I mean, a dermatomal examination. That is a clinical importance of dermatome. Very simple we think, but it has a very, very important implication in our practice also. Even holding a patient, how firm you hold while doing passive movement. If you know that there is a loss of sensation, then you should be very careful in holding those things.
And next question is from Mr. Jitender. Sir, while assessing the dermatomes, we should assess all the sensations for one particular dermatome?
I can't understand. You have to assess all the sensation?
For assessing one particular dermatome?
Yeah, that variety. As I told, this dermatome assessment helps us to map which area is affected. Then it characteristics. Characteristics means what and all affected in that area, not skin means the dermatome. So once you come to know that there is a problem, then we will go for all the assessment. Which one is affected, we have to find. We can't say that, as I told, that touch dermatome is more, tactile dermatome is more, pain dermatome is less, like that. So we have to assess properly. All the things we have to assess. There is no choice. We have to assess. Once you, that's why I told you can start from distal to proximal. We can't assess all the, randomly we can check. If you find there is a problem, at least one point at one dermatome we have to assess. We can't leave as of upper limb. At least T1, one assessment. C8, if you find there is a problem, then you have to assess full dermatome. All the sensations, all the type of sensation you have to assess.
Fine, sir. And few thank you messages in between.
Okay.
And next question is from Ms. Umayal.
Hmm.
Sir, please say about diabetes and dermatomes.
Diabetes and dermatome, we get peripheral neuropathy in diabetes. So because of peripheral neuropathy, skin may be affected. Like that only we can correlate. As skin is affected, we can find which dermatome is affected by using the assessment, and mainly for precaution purpose only. Mainly for precaution purpose, you can use this. I think now audio is clear, I think.
Yeah.
So precaution purposes, you can use in diabetic. Mainly we use for that only. In diabetes, we are not going to treat with that assessment.
Yes, sir. Next question is from Ms. Anisha Singh. Sir, what is protopathic sensation and epicretic sensation?
Yeah, that's why I told epicretic sensation group of what to say, group of senses carried by epicretic. Protopathic means pain. Those sensations carried by certain receptors. The pathway is different, as I explained. So according to the pathway, according to which receptor it's carrying the information, we name it as a protopathic or epicretic.
Yes,
So
sir.
protopathic pain is very important. You can search also in Google also and find, because the term we are not using generally.
Fine, sir. Next question is from Ponmadi ma'am.
Oh, she's awesome.
Evidence-based
Unexpected.
concept. Yes, sir.
Yes.
Evidence-based concept
Yes.
you want to share on this topic, and the area you think to be explored by students more to improvise its importance.
No, I can understand what.
Unmute her, unmute.
Ma'am,
Ponmadi madam தானே அவங்க தானே
ஆமா.
Sir, nice presentation, sir.
Good evening, madam.
Sir, just இது எவிடன்ஸ் பேஸ்ட் என்ன நம்ம இன்னும் பண்ணா இதை இம்ப்ரூவைஸ் பண்ணலாம் அப்படின்னு சொல்லுங்க சார். ஏன்னா நீங்க லாஸ்ட் ஸ்லைட்ல வந்து யூ ஹேட் கிவன் a point that நீங்க எதை வந்து you think that it's more evident, you have to follow. You had said that point. That's really nice. So you just share like how we can do more research in it. என்ன வேலை பண்ணா we can improvise it, because all concepts are very old concepts, as you said.
Yes.
We have to improvise ourselves. So experience, I want the answer. Like I want it from your experience.
No. Experience means we can't do anything because we are physiotherapists. So that's why I told at the last slide also, only clinical anatomy, they have to do a research and find the proper, because it's a very old map we are using. Now latest at that time they have given an injection, they have desensitized, then they found which area that spinal segment is, spinal root is these, like that only they found. Now there are a lot of technology has improved, but still they didn't try to find one thing. That's why our part is at least we come to know there is a map called evidence-based dermatome that we can use. Some areas they didn't say, so for that areas you can use older maps only we have to use, because our part is very less. Otherwise we can use in your research and all, we can use evidence-based map than older map. If you are treating a patient, a CP patient, you are doing a technique to improve the muscle activity through dermatomal stimulations we are doing. At that time, we can follow that evidence-based mapping.
Okay.
Better, I think.
Thank you, sir. So anatomists should work on it.
Yeah, clinical anatomy is the thing.
Sure.
There is a group, there is a branch called clinical anatomy.
Sir, thank you so much.
Thank you, thank you.
Next question is from Ms. Nitya Selvam. If tactile is affected or any one sensation is affected, what is the treatment protocol? How it have to be different?
I think, I don't know how it's different means I don't understand, but sensation is affected means we have to find two ways. It can be affected. That is one, it can be it be increased or decreased. Abnormal. Normal, it's not normal. Abnormality can be one, it can be more sensation is there or less sensation. According to that only we will be deciding the treatment. One thing, if it is hypersensitivity means we will go for a lot of training which makes that to forget that sensitivity. That is, we keep on giving the movement, so the sensitivity to that area will be reduced. Keep on touching that area. They say if it is low sensitive, hypersensitivity, our treatment will be totally different. We try to give lot of information on the dermatome, so we expect that this information is going to the nerve, to the brain, and brain will register that and that area will again function as usual. That is a treatment now we are giving. Desensitization, what I told before, that is hypersensitivity, we are desensitize the part, and one thing. Another thing, we have to improve sensation by giving lot of stimulus.
Fine, sir.
Any other questions? Somebody was raising hand. Rupesh, Evangeline.
Yes,
You
sir,
can
but
unmute her. Then
she's not having her mic, sir.
okay. Ask her to type the message if she is having doubt. Evangeline, you can type your doubt in the chat box. Is there any questions on YouTube?
No, sir.
Okay. Shall we conclude it?
Yes, sir.
Yes, Tuna madam, unmute your mic, please, and please conclude. Unmute, please.
Yes.
There is a question in YouTube, I think.
Yeah, okay. Kindly check it, please.
I'm forwarding.
So one more question in the chat box.
Yes, sir.
No problem.
From Dr. Ria, sir. If lesion is at C8, then both dermatome and myotome will be involved.
I think they're asking spinal cord injury, I think. Then if it is a complete spinal cord injury, then there will be both motor and sensory, depending on where there is an injury, whether it is from laterally inside or from above cut. We have different type of injuries in spinal cord. According to that, you may show. But if it is a complete spinal cord injury, both will be showing. There's no. If it, I think she's saying about spinal cord injury. If it is IVDP like that, mostly there will be pain. Then motor, sensory will be more affected.
Fine, sir. Ria, are you satisfied?
I'm asking if there is, we find that dermatome is affected, then we have to check simultaneously myotome also. Means they both are simultaneously affected, or it is not always compulsory that dermatome only will be affected or myotome only will be affected.
No, you can check, no problem. You can check both dermatome and myotome. As I told earlier, you have to check both the things. If dermatome, sometimes it may be confusing because one dermatome has a larger area. So, and there is a lot of overlap. So, dermatome may not show there is a changes in sensation, but myotome clearly shows. Then you have to give importance to myotome, and you can give less importance to dermatome, and you can come to a conclusion or diagnosis with the myotome itself.
Fine, sir. And one question is from our YouTube viewer. In partial injury of spine, is the chance of regaining dermatomes is faster than the normal spinal nerves?
Injury, spinal nerve injury, they are saying, I think.
Yeah, partial spinal nerve injury.
No, partial spinal cord injury.
Yes, sir.
Spinal cord injury, they are saying.
Yes, sir.
Partial spinal cord injury, regaining is very difficult. If it is a peripheral, once that comes out of the spinal cord, once it comes out to the ramus, root, then lot of things is changed. Once it becomes peripheral nerve, then you can lot of chances of regeneration coming back and all. Once it inside this central nervous system, half of the spinal cord is cut. It's very difficult to bring back.
Fine, sir. Participants, any more questions? Do you want to speak out?
I think.
Evangeline is
One
raising her
question is
hand.
sent to me privately, but
Yeah,
actually, I think I cannot pronounce it properly.
You try it, we will help you, no problem.
It's from Kesavan. If extremity or trunk level means we can record this level like C3 or C4. If head or face means how to notify, sir?
Yeah, if head or face, again there is a dermatome C2, C3 in the head, posterior part, and trigeminal nerve, as I told earlier. Because spinal nerve, it's not going to the face part, trigeminal nerve. So you have to say which division or which branch of spinal nerve is affected. You can record according to that. Dermatome is mainly by spinal nerves. I mean, cranial nerve there, over the face and not spinal nerve.
Fine, sir.
Thank you. I think no more questions now.
No, sir.
Yeah. Duna madam, we can conclude now.
Fine, sir. So thank you everyone for patient listening and staying with us. I would like to thank our resource person on behalf of Team ExRx India and our volunteer for today, Priya, for helping us in creating the group and managing our question and answer session later. So, sir, this is a beautiful presentation and such informative things in whatever the time we have given you, and you have prepared it and you have presented it is very wonderful, sir. You patiently answered to all our queries of the participants. So thank you very much for that, sir. So would like to conclude here and
I want to say
yes,
thank you, Chandramogan and Rupesh, for giving this opportunity. And I also thank you, Duna madam, for tolerating me that audio problem and all. Thank you everyone for patiently listening, because it's not a art topic like what you call dry needling or anything. But anyway, they listened and they asked question also. That is very good. That means they listened.
Yes,
very happy and very thank.
After they are listening, sir. Otherwise, these many questions won't come.
Yeah. Good crowd you have. They are listening.
Thank you, sir. Thank you so
that
much.
Is very important. Again, I thank Rupesh and Chandramohan.
Thank you, sir.
Thank you.
Sure, sir.
Thank you, sir. Good night, all of you.
Good night.
Good night, sir.
Good night. Good night.